What we do here is go back.
Good morning, everyone. It's 8 a.m. and we're getting ready to start. So thank you very much for joining us this morning. Many of you would have worked with this morning's speaker at some point early on in your career. Our speaker this morning is Dr. Corrine Sin Quee. She is the only pediatric hematology oncologist in the Bahamas. She is a UE graduate who pursued residency training in New York, New Jersey. She returned to the Bahamas immediately after completion of her fellowship training at New York University in 1991 and is board certified in pediatrics and pediatric hematology oncology. She is a member of local and international medical organizations and has maintained important links with many of her US and Canadian colleagues with ready access to current treatment protocols. She's also a lecturer in child health for the University of the West Indies and is actively involved in the postgraduate training in pediatrics and family medicine. She has served on the executive body of the Medical Association of the Bahamas and has organized and co-chaired several of its annual conferences. Dr. Sin Quee is seen as one of the field's active leaders in the Caribbean region. She is an instrumental part of Sick Kids Caribbean Initiative, serving as co-lead physician for the Caribbean, and feels it's an important project in pooling resources and working together to improve the quality of care in cancer and blood diseases for our children in the region. The initiative also broadened her involvement at an international level, with involvement as part of the PAHO Childhood Cancer Working Group and as the Bahamas National Coordinator to the ASH Children's International Consortium on Acute Leukemia, CICAL. She is also a strong advocate for children with cancer and blood diseases and serves as the medical advisor to the Bahamas Sickle Cell Awareness and Hemophilia Association. And as you know, this is Sickle Cell Month. She is married to a classmate, Dr. Conville Brown, who we all know, and they have 3 wonderful adult children. So welcome, Dr. Sin Quee. Thank you very much for speaking to us this morning.
Okay. Good morning, everyone, and thank you very much, Dr. Black, for the introduction, and thank you very much for the invitation to speak. And let's see if I can. So, yes, you're right. Today is one of the days in September, and September is Sickle Cell Awareness Month. And I'd like to recognize that I have on burgundy this morning, and this is the official color for sickle cell disease. And this has been adopted by the Bahamas Sickle Cell Association. And I'd like to, mention that they're very active right now in trying to promote awareness and support the local sickle cell patients who are here. So I'd like you to lend some support to the organization. I have no financial disclosures to report. And the objectives were sent earlier. We're going to be able to look at the prevalence and presentation of gallstones in patients with sickle cell disease, determine the role of imaging studies, describe treatment options, describe the indication for ERCP, describe outcome with regards to laparoscopic versus open cholecystectomy, describe potential complications, look at the Bahamian experience, and determine the approach for patients who are symptomatic versus asymptomatic. So I'd like to start off by giving you 2 real cases. One is a 7-year-old girl with SS disease who was seen last year on routine visits. She had no prior hospitalizations, and she was admitted, she admitted to intermittent mild right upper quadrant abdominal pain just for the past week, but this had not interfered with her activity. She had mild pallor and was anicteric on examination, and the rest of her examination, including the abdomen, was benign. Her hemoglobin was 9.6 as a baseline value, and the ultrasound did confirm the cholecystectomy that was suspected. There was no evidence of cholecystitis, and there were multiple small 2 to 3 millimeter calculi. The common bile duct was normal. So I put this out to you because, it's not uncommon for this presentation. And I ask you, what is your plan for this child? Should we watch and wait? Or should we refer this to the surgeon urgently, or can this wait until later? So this is what we did, or what I did. I plan to refer it to the surgeon with the intention for him or her to arrange elective cholecystectomy at the earliest convenience. And I tried to do it during school vacation. She had no gallstones, and this now would have been a year since I saw her in that visit. But unfortunately, she had a different complication from her sickle cell disease. She had a stroke with seizures, required exchange transfusion, and is now on a chronic transfusion protocol. She was referred and had, in fact, been scheduled for surgery for her cholecystectomy. And this has, as with other cases of elective surgery, been postponed because of COVID. So this is the first case. So this would be a case of symptomatic polylithiasis. Case number 2 is an 8-year-old boy, seen last year too, in November on a routine visit. And this boy also didn't have any prior hospitalization, never had any painful crisis, specifically never complained of any abdominal pain before, and on an examination had mild pallor, was anicteric, and his rest of the examination, and in particular his abdominal examination, was benign. His baseline hemoglobin was 7.3. In January of this year, he presented to the pediatrician for right upper quadrant abdominal pain with marked jaundice. His hemoglobin was 7.6, similar to his baseline. But of note, the bilirubin was 41 with a direct of greater than 20. So this was a direct hyperbilirubinemia. And the ultrasound confirmed polydopolithiasis with a 3.4 millimeter calculus in the common bile duct, and that the common bile duct was also dilated. So I asked again for you to look at this one and ask yourself, what would be your plan for this child? So this one was easy. So this is the first presentation of polylithiasis with obstructive jaundice. And because the stone is in the common bile duct, likely from the presentation, this is a case of polylithiasis. This child needs urgent admission and evaluation. And that is exactly what the pediatrician did. He sent the child to the emergency room and called the pediatric surgeon, who was able to contact GI as well, and the child was admitted. The child got parenteral analgesic with morphine. IV fluid hydration was begun, and the intent was to monitor for associated complication and plan for whether or not they would be able to do ERCP on this child. And the intent that, we'll probably go on to cholecystectomy, but the first step would be the ERCP. A repeat study done on day 4 showed a 1 centimeter calculus in the terminal common bile duct. The common bile duct and the intrahepatic biliary radicals were dilated, which is in keeping with obstruction. And here's one of the complications that is well recognized in patients who present with abdominal pain. And so with this presentation associated with the abdominal pain, you oftentimes see hypoventilation and splinting. And with this, it is not uncommon for you to have acute chest syndrome. And even though the initial chest x-ray on first glance looked like it was okay, it was normal, if you look more closely, you can actually see that there was the start of some infiltrate in the left lung. And look at what happened 2 days later. In 2 days, we have almost complete whiteout of the left lung. And if you look carefully on the right side, you can also see evidence of the start of some consolidation. And this, in fact, is a common thing for acute chest. The rapidity of progression is very worrisome and should be a great alert for all of us. He was only with us for 1 week. And in that time, he had to be intubated and ventilated. ERCP was done. But even then, post-op, he still had problems. He required exchange transfusion. His respiratory distress got worse. He had ARDS, complication with pneumomediastinum. He had evidence of multi-organ failure, and the decision was made to transfer him to Miami Children's Hospital for further care. While there, he also developed a yeast infection. He never got off the ventilator, had to have a tracheostomy done, and he remained hospitalized and died approximately 4 months later. Sickle cell disease is a hereditary condition caused by the substitution of valine for glutamic acid at position 6 on the beta-globin chain. Gallstones are frequent complications in children with hemoglobinopathies like sickle cell disease because of chronic hemolysis leading to an increase in bilirubin excretion and pigment gallstone formation. The incidence of gallstones in children with sickle cell disease has increased over the years due to both regular use of ultrasound and the longer survival of these patients. And I just put up this slide to review the bilirubin metabolism. Majority of bilirubin comes from the red cell breakdown. And here, this shows a normal lifespan of red cell of 120 days. The lifespan of sickle cells is only 10 to 20 days. So you can imagine that with such a short lifespan, you have a lot of red cells, old red cells being presented to the system. Breakdown of hemoglobin occurs. The heme is broken down to biliverdin and then bilirubin. And this is in the mononuclear phagocyte. Then this is carried to the liver by the bloodstream where conjugation occurs within the liver. And because of the increased bilirubin load, pigment stones are commonly seen in patients with sickle cell disease. So here are some of the gallstones that you would have been accustomed to seeing. Most of the gallstones that are seen in persons other than the people with hemolytic disease is actually cholesterol stones. And these cholesterol stones are commonly seen in patients who are female, over 40, fat, flatulent, the 4F factor. They're usually large or maybe large. They're radiolucent. And oftentimes you only have one stone. And this is unlike the bilirubin stones or the pigment stones, where the sex predilection is not for male or female. And we can see bilirubin stones in patients as early as 2 years of age. By 10 to 14, about 22% of patients have been reported to have gallstones. And by the age of 30, over 50%, and later on, over 70% have been reported to have gallstones. So this is common. We expect the gallstones to be there, but they're not necessarily always symptomatic. And we see them more commonly in patients who have SS disease and S-beta-thal-0 disease. The stones are usually small, and they are radiopaque because the composition is a combination of calcium carbonate and bilirubinate, and the stones are usually multiple. So this just shows a schematic representation of where the stones can be located. It can be located within the liver itself in the hepatic ducts. And most times though, it is seen in the gallbladder. And because the gallbladder is a bigger capacity, the stones, even though you might have some pain, oftentimes don't cause any problems. And not uncommonly, it will slip through the ducts, travel in the common bile duct, enter the intestine, and be passed out in the stools. However, sometimes these stones actually cause issues, and you can have a stone that is lodged in the common bile duct, and this is called choledocholithiasis. So in a common bile duct, this would give you more of an issue. We mentioned symptoms, but I want to highlight that a lot of the patients with gallstones and sickle cell disease have no symptoms whatsoever. But when they are symptomatic, the commonest symptom is right upper quadrant pain. It is the most frequent complaint. It is oftentimes intermittent. There's varying intensity of the pain. It's usually dull. It may be associated with fatty meals, and it may be associated on examination with some tenderness. You might get some nausea and some vomiting. But if a patient who has gallstone presents with right upper quadrant pain and marked jaundice, you need to consider that there is obstruction within the common bile duct. And then if they have fever, severe colicky pain, and tenderness at McBurney's point, then you need to consider cholecystitis, which only occurs in about 10% of patients. So the investigations that you want to do in patients who you suspect to have gallstone, you do a CBC to see what the baseline hemoglobin is, the liver function test, in particular the bilirubin, the total and direct, alkaline phosphatase, the transaminases should be reviewed, and the serum amylase is put there because patients can have associated pancreatitis as part of the picture of a complication. The little table on the side just highlights the different things with cholelithiasis and choledocholithiasis. So with cholelithiasis, you will expect them to have intermittent right upper quadrant pain. They may or may have a little bit of fever and some jaundice. The transaminases are oftentimes normal or mildly elevated, and the bilirubin is normal or mildly elevated. We see sickle cell patients all the time, and you expect them to have gallstones, so they have cholelithiasis, but the baseline values are not affected. However, if they present with right upper quadrant pain, fever, increased jaundice, then you think about a stone in a common bile duct, in which case the transaminase again may be normal or mildly elevated, but the bilirubin is markedly elevated, as was in case 2 that was presented. The alkaline phosphatase is also elevated in these patients. So the investigations that you want to consider are ultrasonography, HIDA scan, MRCP, CT, ERCP, and abdominal X-ray. And I put all of these there because what you're trying to do is to confirm the presence of gallstone. And even though we mentioned that right upper quadrant pain, the consideration for gallstones is highest on the list, we do know that you can have cases where you have pain that is not related to gallstone, and this is considered as an abdominal crisis and just requires hydration. And this is important to recognize because sometimes you do surgery thinking that you will fix the intermittent pain that these patients may have, and after you do the surgery, remove their gallbladder, they still continue to have pain. So this table goes through the different diagnostic studies, and they are listed in order of preference. So ultrasound has a high specificity and sensitivity for gallstones. It's inexpensive, non-invasive, and should be the first line test for patients who you suspect to have gallstones or acute cholecystitis. And it will, in addition to giving you information on the stones themselves, will be able to give you an impression of the liver parenchyma and whether or not there is any supportive evidence of cholecystitis as well. The HIDA scan, hepatobiliary immunodiacetic acid scan, is also another test that can be done, and this too has a high sensitivity. and it is useful to visualize the biliary tree and to assess the liver anatomy. However, this is not readily available, so it's a little bit more difficult to get this scan done. MRCP has a high sensitivity and specificity for identifying gallstones. It's non-invasive. It is available locally, so this is the one that can be done at doctor's hospital. We don't have it at PMH. However, if you really and truly think that there is evidence of polydocylithiasis on ultrasound, which is where you would initially suspect it, it's probably better to go to an ERCP, because in this study, you're not only able to see the same thing that MRCP will give you, but you are able to also remove the stone and perform sphincterectomy and gallstone extraction. CT scan can be done too. It's superior to ultrasound, but it comes at a higher cost, and there's exposure to radiation. So it's, it's an option if you don't have access to the ultrasound, or the ultrasound machine is broken, but it's not the first study of choice. I leave the plain X-ray at the bottom, and I want to mention that because of the calcium carbonate that is combined with the bilirubinate, bilirubin stones are actually radio-opaque, unlike the radiolucent cholesterol stones. So you can see these stones on X-ray, and it is also useful excluding other causes of acute abdominal pain, intestinal obstruction, visceral perforation. So, it has this place, but it is definitely not the study of choice when you're thinking that this is gallstones. Here are a few of the complications that we should anticipate can happen. You can have infection, acute cholecystitis, or it could even be chronic. We mentioned before that the stone can migrate into the common bile duct and cause obstruction. You can have ascending acute cholangitis. Acute pancreatitis is a possibility. Empyema of the gallbladder, obstructive jaundice, cholecystoductal fistula can occur as a complication, and gallbladder perforation has been reported. I highlight separately acute chest syndrome, and this actually is a perioperative problem. So you can have acute chest syndrome that occurs even before surgery, and definitely after surgery continues to be a great issue. So acute cholecystitis, as we mentioned before, can be suspected if the pain is steady. It lasts longer than 6 hours. It's associated with fever and chills, and Murphy's sign is oftentimes positive. The white cell count is oftentimes elevated in this complication. And with pancreatitis, definitely we'll want to look at the serum amylase and lipase levels, which would be elevated. So we go on to treatment, and I think this is the highlight of this talk, and for you to realize that there are several approaches, and if you go online to look up and try and get an algorithm to see what is the recommended treatment, you realize that there is no agreement as to what to do in every case. Can do conservative and expectant treatment. ERCP, as I mentioned earlier, is diagnostic and therapeutic, and it is indicated if you have a stone in the common bile duct, evidence of common bile duct dilatation greater than 6 millimeters seen on ultrasound, but there's evidence of ascending cholangitis. And this study can assess the biliary system well and can identify the bile duct obstruction. And therapeutic intervention to relieve the obstruction can be done by actually dilating the sphincter and removing the stone. Cholecystectomy is also the next consideration, and the things that you can do is either laparoscopic or open. So let's look at the advantage and disadvantages of each. So with expectant management, it avoids overtreatment, it avoids anesthesia, and we all realize that our sickle cell patients are not patients you take for granted. They have a higher anesthesia risk, and complications can occur and death can result. It avoids unnecessary costs and workload for the healthcare system, and especially in these COVID times, I suppose expectant management is attractive. However, it is the potential for the development of serious complications while waiting is a major issue. And if you delay the consideration for surgery and leave it until they are older, then you might have increased comorbidity, as well as having to perform the intervention more in an emergency setting, which is associated with increased morbidity and mortality. Routine cholecystectomy is definitive cure. And it's generally a safe procedure with low morbidity and mortality, especially when performed in the absence of complications. However, if we were to do routine cholecystectomy in all patients who have gallstones, then we might overtreat a large number of patients who may never have become symptomatic at all. The potential for morbidity, mortality of anesthesia and surgery is there, and of course, increased cost and workload for the healthcare system. So the other consideration is that maybe we should just do selective cholecystectomy. And theoretically, this is ideal, as we'll be able to identify the higher risk group and then just do the surgery or the intervention on those before complications occur. However, this is practically difficult, as clear indication of the high-risk subgroups is still far from easy. So when you look at lap cholecystectomy, which has emerged as the modality of choice for surgery, we recognize that post-op respiratory performance is improved, post-op pain is reduced, post-op mobilization is oftentimes earlier, the hospital stay is usually shortened, and who wants a big scar as opposed to 2 or 3 little scars that you get from lap choles. However, not all persons believe that this is the choice for surgery. So it doesn't have the full support, because we recognize that in order to perform lap chole, you have to insufflate the abdomen with CO2. And that in doing so, you might increase the risk for acute chest syndrome. And Wales et al. Reported that it did not necessarily decrease the incidence of acute chest compared to the open approach. And so there's still debate, but I think that the overall impression in the literature that I saw was that lap chole is now the modality of choice. And from what I understand, it is probably unlikely that you will be able to get reimbursed at the insurance level unless you have good justification to have proceeded to open cholecystectomy. So this is a study out of Egypt, and they looked at the 42 cases that went on to surgery. Group A consisted of 30 patients for whom elective cholecystectomy was performed, and they were all asymptomatic, and they reported basically little morbidity in these patients. Only 4 of the patients had any complications, and the post-op hospital stay was 2.4 days plus or minus 1. And if you look at the other column, which is the group B patients, and these were patients who presented with symptoms. So they had either biliary colic, acute cholecystitis, acute pancreatitis, or cholelithiasis, that these patients actually had to get, for the most part, emergency intervention. They had higher morbidity complications, and their post-op hospital stay was longer. So it was 5 days as opposed to 2 days. This is another study out of Italy. And in this study, they looked at what happened to patients who initially were totally asymptomatic when they were screened and picked up to have gallstones. The total number of patients was 30. They were able to convince 16 patients to have elective lap cholecystectomy. These were of a slightly younger age than the other group. So they were a mean age of 13 in this group. And you recognize that there was little or no complications at all. They looked at the group of patients who refused elective cholecystectomy and recognized that these patients ended up going on to having complications. 10 of them presented with complications requiring emergency attention. They had biliary colic, cholecystitis, and obstruction. 10 required emergency lap chole. 1 ended up having to proceed to open cholecystectomy because of complication. And there was 1 patient who had ERCP and then lap chole. But to be fair, I wanted to highlight too that there were 4 patients in this group who refused any intervention and who up to 40 months later had had no symptoms whatsoever from their gallstones. So the conclusion from the author was that elective lap cholecystectomy should be the gold standard in children with sickle cell disease who have asymptomatic cholelithiasis to prevent the potential complications of biliary colic, acute cholecystitis, and cholelithiasis, which can lead to major risk, discomfort, and longer hospital stay. This wasn't necessarily just for sickle cell patients, but this showed what happened to asymptomatic gallstones. And if you look in the column for those who develop biliary colic, that up to 25–26% of patients who may have been asymptomatic can progress to having symptoms within months to years. And the other complication that we mentioned earlier is also an ever-present issue. So I place this here just to remind us about the evidence-based management of sickle cell disease that was produced by the expert panel in 2014. And this is a National Heart, Lung, and Blood Institute study with this recommendation. And this is to highlight whether or not prophylactic perioperative transfusion is warranted. They did recommend that in adults and children with sickle cell anemia to transfuse packed cells to bring the hemoglobin to a level of 10 grams per deciliter prior to undergoing surgical procedure involving general anesthesia. It is listed as a strong recommendation with moderate quality evidence. The Jamaica cohort experience, though, suggests that this may not necessarily always be right. And Professor Graham Sargent from Jamaica probably has the largest study of sickle cell patients in the Jamaica cohort study. And, you know, I remember as a medical student being aware of this project. And he was very diligent with everything that he did and was able to change the landscape for consideration of what must be done to what can be considered differently. So in Jamaica, they don't always transfuse patients to the hemoglobin of 10 grams per deciliter. But I did want to highlight that this is a recommendation that came out because when they transfuse patients, they recognize that the complications, the post-op complications of acute chest syndrome in particular, was much, much less in the transfused group compared to the non-transfused group. The other recommendation was that in patients with SS disease who require surgery and who already have a hemoglobin level that is higher than 8.5 without transfusion, or who are on chronic hydroxyurea, or who require high-risk surgery, that you consult a sickle cell expert for guidance as to the appropriate transfusion method. So, you know, at least it was recognized that maybe in patients with a higher hemoglobin level, maybe just doing some simple things like warmth, hydration, oxygenation might be sufficient to avoid the transfusion. So this was a strong recommendation, but the quality evidence was not necessarily the greatest. In adults and children with hemoglobin ST or S beta thal plus thalassemia, consult a sickle cell expert to determine if full or partial exchange transfusion is indicated before a surgical procedure involving general anesthesia. It's a moderate recommendation, but again, the quality evidence is low. So I think this just highlights the consideration of whether or not you should transfuse the patient before surgery to put them in a better position and decrease the post-op complications that may occur. So I decided to look at any published data for the region, and I tried my best to gather some information for the Bahamas. So in the Jamaica study looking for the period 1999 to 2004, they had 16 patients. The mean age in that study was 28.5. They were all done, the cholecystectomy were all done because the patients were symptomatic, so there were no interventions on asymptomatic patients. They were all by lap chole. The conversion rate from lap to open cholecystectomy, I thought was a little high at 25%. And even in their latest study, it was up to 28%. The pre-op hemoglobin average was 7.6. And I thought the post-op complications were high too. So you have 50% of the patients who had post-op complications, with 6 who had acute chest syndrome and 1 who died. The latest study from 2009 to 2014 by Pierre Anthony Leek also had a small number, 27 patients. This included even the adult patients. Again, the indication was for symptomatic disease. The mean time from presentation of symptoms to surgery was about 8 months. And you had a ratio of 2 to 1 of cases that were handled either laparoscopically or by open cholecystectomy. I thought that was a little unusual because I thought that we would have had a greater number of just lap choles that were done. So I was surprised to see that. The conversion rate from lap to open was also high, 28%. And in this study, there was 1 patient who had pre-op transfusion. It was reported, though, that bile duct evaluation was performed in almost all of these patients. you had a 48% 30-day mortality. I thought that was disappointing. I was impressed by the Trinidad study by Dan Dillip, who looked at the period of 2003 to 2008. So in a 5-year period, he had 19 patients. The average age was 21.5 years. All the cases were done because of symptomatic disease. I'm sorry, there was 10.5% who actually had symptomatic, who were asymptomatic and had elective cholecystectomy. So I correct myself on that. All of the cases were done laparoscopically. The pre-op hemoglobin in that group was 8.2. 21% had some form of bile duct evaluation, and 4 of the 19 patients had pre-op ERCP. The post-op complication was only 4, with only 1 patient having acute chest syndrome and 0 30-day mortality. I want to recognize that getting the information for the Bahamas was a little bit difficult, but I did the best I could with regards to giving some preliminary data. And in both institutions, with the introduction of electronic data collection, this made life a little bit easier and made it even possible to be able to at least give you some ideas of the numbers. So from what I could see, looking in the PMH database, for children less than 18, there were 13 cases of cholecystectomy that were performed. And the average age for them was 14.6. The age range from 9 to 18 years. None were done for asymptomatic patients. And 3 were done because it was urgently needed. All but 1 was done laparoscopically. I could not give you any information of anything else, unfortunately, because I didn't have enough time to be able to gather that data. And I was told that out of the 81 cases of, that should be ERCP, that we have somewhere between 4 to 8 who would have had sickle cell disease as the indication for the procedure. To the best of my knowledge, during this study period, we do not have any reported 30-day mortality. Over at Doctor's Hospital, I was able to get a little bit more information. 13 cases out of a total of 459 cases of cholecystectomy that were performed on patients with sickle cell disease. And it's mainly in the adult population. None were done because the patients were asymptomatic. And ERCP, not MRCP, was performed in 4 patients. I put in brackets that the acute chest syndrome occurred in 1 patient, the one that I described in case number 2, but recognize that acute chest syndrome actually, in his case, occurred before the surgery. So I'm not sure I could include it as a post-op complication, but the whole thing progressed and was fatal. And his mortality was outside of the 30-day period, but I put it there to recognize that this was indeed an issue. So our local data is preliminary only. And if you look at the numbers, we have at least 26 procedures that were performed on patients with sickle cell disease over the 5-year period. And looking back on the regional studies, you realize that our numbers are similar to the numbers reported in the studies from Jamaica and Trinidad. So we do have enough information there that we can review our data more carefully and to be able to contribute to the literature and possibly make contribution with regards to recommendations going forward. Majority of the cases were done laparoscopically, not by open procedure. 8 to 12 patients had ERCP. The complication rate is to be determined. And as I mentioned before, one patient had perioperative severe acute chest syndrome and later died. This gives us room for further research in order for us to be able to better present the information on these 26 cases. So then I try to look up algorithms for the management, and I think that you can see that there are some recommendations in an algorithm, and for sure, if the patient has no symptoms but has hemolytic disease, then prophylactic cholecystectomy may be offered, or conservative management may be the way to go. But definitely, if they have symptoms and complications, then this directs your path differently. And oftentimes, patients with symptoms would go on to needing cholecystectomy. And then the bottom part is just to highlight the complications of acute cholecystitis, cholelithiasis, cholangitis, and acute pancreatitis. So if you do have a patient who has a cholelithiasis, you need to decide whether or not the likelihood is low, in which case lap chole can be considered, intermediate, in which case lap chole can be considered. And if it's high, you basically need to go on to ERCP and lap chole ultimately. The National Heart, Lung, and Blood Institute of the United States recommend, from evidence-based management of sickle cell disease, that asymptomatic gallstones should be treated with watchful waiting in children and adults. But when symptoms do develop, cholecystectomy should be performed laparoscopically if feasible and available. So here are my recommendations. Patients who are symptomatic should be assessed and refer at the earliest for elective lap cholecystectomy. ERCP should be done if indicated. So if you think that there is a gallstone in the common bile duct, for sure ERCP should be a part of the workup. You need a team approach for perioperative care. The pediatrician, the pediatric hematologist, oncologist, the surgeon, the gastroenterologist, and anesthesiologist. I always promote that pre-op intensive spirometry training would be helpful to prevent the acute chest syndrome that is very likely after surgery because of the post-op pain. As I mentioned in my presentation, pre-op packed RBC transfusion should be considered. I wouldn't say that I recommend that all patients should be transfused, but for sure, it should be something that you think about. Perioperative attention to hydration, oxygenation, warmth, and analgesic is highest on the list. And I was impressed by the Trinidad group who selected the most experienced surgeon to do the procedure on this high-risk group. And in so doing, they were able to report shorter operating time, and he also used low insufflation pressures with his lap chole procedures. So I am hoping that this is what is being done in our setting, because you might not have two chances to do it right. And clearly, acute chest syndrome is a major complication that increases morbidity and mortality in this group. So remember that when considering treatment for asymptomatic gallstone, the aim is not alleviation of a chronic or debilitating condition because they don't have any symptoms, but it's really the prevention of a potential future problem. And patients who have their gallbladder removed electively tend to have fewer complications and a shorter recovery. So here are my recommendations for the asymptomatic patient. I think that routine follow-up of patients in sickle cell disease should be done twice to 3 times per year. And that in these follow-up visits, screening questions specific for checking for cholelithiasis should be done. The family and the patient should be educated of potential complications. I don't know, after this experience with this child who died, I wonder if we should have ultrasound done around the age of 10. And I'm not even sure if I found a stone on the second child, whether or not I would have gone on to elective cholecystectomy. But I do want to highlight that we should all consider elective lap cholecystectomy if gallstones are detected. I'd like to invite Dr. Cooper and Dr. Monroe for comments with regards to the GI side and surgery side. I think Dr. Cooper is present.
Yes, good morning. Can you hear me?
We can hear you.
So the role of the gastroenterologist in the management of patients with sickle cell disease is usually for hepatic or biliary complications. The term sickle cell hepatopathy refers to a group of presentations or diseases that sicklers sometimes present with. Cholelithiasis and choledocholithiasis are only one entity in that group of diseases, but sicklers also will present with ischemic hepatopathy from acute sickle crisis. They'll also present with sickle cell hepatopathy from cholestasis. So there's sickling that goes on in the hepatic sinusoids that will give you a picture very similar to biliary obstruction, with a dramatic increase in your direct bilirubin, with increases in your alk phos and your GGT, which are common in biliary obstruction. And these patients can go on to develop cirrhosis, just like somebody who would be drinking alcohol every day. And then there are those patients who will develop cholecystitis and will also develop choledocholithiasis. I just wanted to mention a few things in relationship to what you've already spoken. We see probably 2 or 3 sicklers who present with choledocholithiasis every year. And anytime you see a patient who has right upper quadrant pain with tenderness, a dramatic increase in their baseline total bilirubin, and any evidence on imaging of a dilated common bile duct, that's very suggestive that this person has choledocholithiasis. One of the challenges in our population is that all of our sicklers are not thin, like you usually expect. And so ultrasounds are often not the best test for us to determine if there are common bile duct stones. The ERCP stands for endoscopic retrograde cholangiopancreatography. The ERCP is the procedure that gastroenterologists perform that carries the highest rate of morbidity and mortality. The complication rates with ERCP sometimes approach up to 15%, which is much higher than anything else that we do. And so an ERCP should be, in ideal circumstances, a therapeutic procedure only. So if you have a patient who presents with symptoms and signs, laboratory investigations, imaging that are suggestive of choledocholithiasis, you really want an imaging test that's going to confirm that before you offer an ERCP to that patient. If your ultrasound is not diagnostic, which very often it's not, because of body habitus, because of bowel gas, then an MRCP really should be performed prior to you performing that procedure. The complications associated with ERCP are acute pancreatitis, which can sometimes be fatal. There's bleeding, there's perforation, so you really want to make sure that you have a stone there that you're going after. And then lastly, the procedure for ERCP in patients with choledocholithiasis and Sicklers is pretty standard. It's just like every other ERCP you would perform, except that in Sicklers, particularly in children, it tends to be a little more difficult. The very young kids, we only have an adult duodenoscope that we use to perform these ERCPs. And so you have to be very, very careful because it's the largest scope that we use. And you have to go down through the esophagus into the stomach, past the stomach into the duodenum to get to where you need to be. And so it has the potential for significant complications because you can also tear the esophagus. When you're going down, it's a blind procedure. And so you want to make sure, it's just reiterating the point that you want to make sure that you know that there is a stone in the common bile duct that you're going after, and not going in there and performing a cholangiogram and finding out that there's nothing there. So those are the few things that I kind of wanted to add in Dr. Sin Quee's presentation, and I'll be available for questions if you have any.
Thank you, Dr. Cooper. I can't see if Dr. Monroe is on the chat, but if there are any surgeons who would like to make any comments, please do so now. And I know Dr. Monroe had promised me to give me some more statistics, except that I think in the middle of all of this is Sister Pa, so deepest condolences to him. After that, I didn't bother to harass him anymore.
Okay, morning. Thank you, Dr. Sin Quee. I see Dr. Shea has asked a question, so I could read his question and then maybe we can get some comments from him. We need to make him co-host so that he can unmute his mic in the meantime. So Dr. Shea's question is, what about lap chole and intraoperative cholangiogram? MRI sometimes is difficult to obtain from the point of view of claustrophobia, and patients are usually jaundiced and ultrasound user dependent.
Oh, I can't answer that one. Sorry about that, Dr. Shea. I would have to ask somebody else in the field to do that one. That one is above my pay grade.
Okay, and so go ahead.
Yeah, no, that's another option because once you're doing your surgery, you can do it an intraoperative cholangiogram, but sometimes they can be difficult. And as I said, MRCP can be very cost prohibitive, and you know that when you go in that MRI, it's very loud and noisy, and you probably won't get a good study because the kids can't keep still. So that's an option that you may have. It may, however, it may prolong your surgery a little bit because of the nature of doing it in an IOC. So that's a possibility. And if you do find a stone post-op, I mean during surgery, then you could do an ERCP. But if not, then you don't have to do the ERCP. Thanks.
Yeah, I was really impressed by this study from Trinidad and recognizing reading it that Dr. Dan DeLip was very adamant about the most experience. I'm not sure if they still do it that way now, because at some stage you gotta treat somebody. But in making sure that all the studies, all the procedures were done by the most experienced surgeon, and in fact, in his paper, he said this is not the time to teach anybody. This was a precious group of patients, and he wanted no complications. So he mentioned too that they decreased the CO2 insufflation pressure, I think it's 12. And in doing that, he found that you had less complications. Can you tell me what your insufflation pressure is for lap choles here?
Yeah, I use 12, 13 myself. I go the lowest, yeah.
Yeah, I learned a lot about surgery in the preparation for this talk.
You must understand, Dr. Dan is a trained laparoscopic surgeon, so he will do the most cases because he's actually trained in that.
Right. Well, then, you know, that's great. I mean, his complication rate was very minimal. I was very impressed with that.
Okay, thank you, Dr. Shea. And so we have Dr. Don Major who has a question, who will also make some surgical comments. But before we get to Dr. Major, Kevin had a question. What about dissolving the gallstones with oral lipase capsules given on an empty stomach? Enzyme therapy should work in this group and also in the adult group?
I don't know if it would work, because remember that these stones are bilirubin stones. Maybe the surgeons can help me out with this too, because this is also something out of my depth.
Yeah, that only works with small cholesterol stones, very small ones. So I don't think it's going to work with bilirubinate stones.
Okay. Thank you. And so from Dr. Yashika, we have, can you comment on the use of pre-op exchange transfusion in case number 2, given his significant lung involvement?
You know, in retrospect, I mean, it's probably a consideration. I think though that more importantly, early recognition of the acute chest syndrome and aggressive analgesic therapy probably would have helped to abort the progression. And even saying so, you know, even a simple transfusion at the beginning might have been sufficient. But I think that the window for intervention in preventing progression of acute chest is a very small window. And if missed, you usually can't go back to and reverse what is going to happen. So this one's a very unfortunate case, very sad case.
Okay, thank you. And Dr. Don Major, you are unmuted, so you can go ahead and ask your question and make your surgical comments as well.
Hi, good morning. Can you hear me?
Yes, we can.
So a few questions I kind of had was, do we actually screen these individuals or these sicklers for cholelithiasis? And if so, what age would we begin screening them at?
I don't usually screen unless they have symptoms. So any issues with abdominal pain, I definitely send them for ultrasound to make sure that they don't have gallstones. And oftentimes the area for the abdominal pain that is always worrisome for me is right upper quadrant. So if they have any symptoms at all of abdominal pain, I send them for ultrasound. But it is not a routine thing. And if you look at the literature, it is not a routine recommendation for screening. And I think that it is important for you to realize too that when you screening is not enough. You have to decide that if you pick it up, what are you going to do with it? So if the next step is that if we screen and we pick it up, we are going to do elective cholecystectomy, then I think, yes, we should introduce a proper screening procedure. But this in itself is not a accepted recommendation at all.
And which is my follow-up question to that is, because these individuals seem to have such bad complications when they do develop symptoms, would it be wise to say, okay, if you do screen them and they are asymptomatic and they have a certain age group, would it be wise to say, let's refer them to a surgeon and probably get that gallbladder out?
You know, that is, I place that as one of my recommendations. That is something to consider. The only problem though is that, let's say you do lap chole for a patient who has asymptomatic disease. And then post-op, the complication of acute chest happens and the patient dies. Then it is a hard sell to say that we should have put it off, not do it at all. And I think this is one of the reasons why it is so difficult to get a uniform recommendation for lap chole to be done on all patients with no symptoms. And this is why I highlighted in this study, in the presentation, that if we could have a crystal ball that could predict the ones who would go on to severe complications, then we could know which ones we should select for elective procedure. But I don't think that that is possible at this point in time. Maybe there'll be other markers that will come about that will be able to predict that and then make our life easier. For now, I think it's going to be an individual case, and from this personal experience, though, it makes me pause and wonder.
Okay. I guess with respect to what Dr. Shea was referring to with the IOC, definitely it is an option for individuals once you're in there, and you can go ahead and do an intraop cholangiogram, but it does add time to the procedure. But ideally, if you can get them some form of imaging to determine whether or not there is a stone in that duct prior to going in, you really want that. That was a question that I had for Dr. Cooper with respect to the age group in which you can do an ERC. Because if you have a pretty young, small kid that has evidence of choledocholithiasis and they may be too young to get an ERCP, then you likely have to go in and do a chole with an intraop cholangiogram and try and retrieve that stone manually. So if Dr. Cooper could comment on basically, I guess, his age groups with doing the ERCP, and that'll be my final question. Thank you.
I think the youngest patient that I have done an ERCP on was 5 years old, and it went okay. It does really make you very anxious and increase your rectal sphincter pressure when you're going into the belly of these kids that are 3 and 4 years old, because the esophagus is so small and the scope is really very big. It's the biggest scope I said that we use. It's even bigger than a colonoscope. So it's when it's absolutely necessary and the patient is at risk of developing cholangitis or biliary pancreatitis, then you don't have an option, but and that's why it's so important to confirm the presence of a stone prior to the procedure. But sometimes you just don't have a choice, and I don't think we do enough cases to really justify purchasing a pediatric duodenoscope. It's about $30,000, and so we kind of have to make do with what we have. But as young as 5 years old, I've done a successful ERCP on, and I hope I don't have to do any on anybody younger than that.
Thank you, Dr. Cooper, and thank you, Dr. Don Major. Would any of the other surgeons like to make a comment before we move on? You can just put it in the chat and we will unmute you. And while we wait for that, Dr. Sin Quee, there were a couple other questions. Is there a role for CT scan?
Remember, I mentioned that as one of the options, except that it's more expensive and it would be second to the ultrasound. So ultrasound is the modality of choice, and I don't think you get much more on the CT scan to warrant doing it, but it is a consideration and it will pick up the stones.
Okay, and what about moving on from that? Dr. Curling is asking endoscopic ultrasound. This one a little bit out of my depths too, so I don't know if there's anybody in the group who can comment on that.
So we do now have endoscopic ultrasound at Princess Margaret Hospital. It's the only place that we actually have in the country, and I think the only place that we actually have it in the Caribbean. Endoscopic ultrasound is a way of identifying. Endoscopic ultrasound, for those who don't know, is basically a regular endoscope that has an ultrasound probe on the tip of the scope, and it allows you to, once you're into the stomach and the proximal duodenum, you can look through the wall of the stomach or the duodenum to see the liver, the biliary tree, and the pancreas. And it gives you as good of an image that you would get from an MRI comparable image, and it's somewhat technically challenging initially, but it's a very good tool for hepatobiliary and pancreatic imaging, particularly useful when trying to identify very small pancreatic cancers or getting biopsies from cancers in the head of the pancreas. But to answer the question, it can be used to identify gallstones in patients who may not be able to get an MRI. The echo endoscope is even bigger, I think, than the duodenoscope. So again, there's a challenge in very, very small patients. But we do have that modality available in the public system.
Okay, Dr. Sin Quee, and our final question is there a sickle cell registry in the Bahamas? And when you after you answer the question, you can give any final comments and closing remarks.
Okay, so the answer to that is that no, there is no registry, but the Bahamas Sickle Cell Association is actively collecting all the names of the sicklers, and I'm impressed with the networking that has occurred in the past, maybe about 5 to 6 years. And you're correct that it is something that we should have established. And we try and see if we can get that done within the next year or two. Just a reminder that this is the month for sickle cell awareness, and you know, give a hug to virtual hugs now to a sickler, wear your burgundy to recognize that sickle cell does exist and it is a major problem in our country. And I would definitely like to encourage one of the DM residents to take on the task of completing the collection of the local data so that we can properly review our situation and to publish it. Thank you very much, and thanks for the invitation to talk.
Thank you very much, Dr. Sin Quee, but I see we have some late comments and questions. I'll just read them. In the absence of cholecystitis or choledocholithiasis on ultrasound and right upper quadrant pain in sicklers, do you recommend medical management primarily or surgical? And I think you kind of went through that discussion, and the surgeons and the gastroenterologists had their comments, but comments?
No, I think we discussed that throughout the presentation. You know, there is a role for the supportive care. So, you know, keeping them NPO, giving them IV fluids, giving them analgesic. But I think ultimately the goal must be to remove the stone. And if the stone happens to pass on its own, then you can plan for elective procedure to remove the gallbladder and to decide whether or not there are any other procedures that are needed for better evaluation of the biliary tree. But, you know, I think ultimately if any patient is symptomatic, we need to be thinking that this patient should have cholecystectomy.
And Dr. Brown would like to remind us that the cardiologists have been doing endoscopic ultrasounds for over 20 years in relation to heart on TEE. So thank you very much, everyone, for participating. And thank you very much for that presentation, Dr. Sin Quee. So just a reminder, please remember to do the feedback. The link is in your WhatsApp, your email, and it was also posted in the chat here. The enrollment key is prophylaxis with a lowercase p. And our next meeting will be the last Friday of the month. Our schedule is fixed, the second Wednesday and the last Friday of the month, which should have ordinarily been Research Day. And the topic being presented at the end of the month is going to be on airway management and anesthesia in the COVID-19 era. So thank you very much. Remember, this presentation is available as a video, and you will see the YouTube link posted on the Sunshine Learner website, so you can participate after the fact and look at the meeting again if you would like. Thank you very much, and everyone have a good day.
Thank you.
Thank you. Bye.